very much. So while this is getting set up, just a quick question for the audience present here. How many of you are routinely doing cross-linking? Great. And how many of you are doing topo-guided treatments? So this is wonderful. So many of you doing cross-linking. I'm telling you at least 50 to 60% of these patients will be eligible candidates for topo-guided treatment. Even if you don't have a laser at your place, but there is a center which you're visiting, it just requires a basic understanding of doing this. And you will be a cut above if you're actually offering an additional treatment to your patients in forms of nuances in topo-guided treatment. So I'll quickly take you all through some of the salient aspects. We have an exciting list of all the topics for keratoconus, various modalities to be covered. And at the end, we also have a wonderful keynote address by Dr. Arif, where he will be talking to you all about combining topography with biomechanics, the newer indices which are available. So do stay back for that. So basically this puts us all in, after cross-linking, what do we do? After cross-linking, yes, we have a stiffening effect, but there is a significant irregularity which is still left behind, which only RGPs may be able to correct. So combining these procedures of CXL plus, the first of which being topo-guided treatment, would go a long way in actually improving the functional visual quality of these patients. So what are we doing essentially in topo-guided PRK? We are attempting to regularize the front surface of the cornea. So essentially, you're trying to do a hyperopic ablation here, that is in the mid-periphery, and a myopic ablation over the steep axis of the, or over the area of the cone. So now what this essentially does is it flattens the cone, as well as it steepens the cornea just anterior to it, bringing about a regularization in the cornea. So what are the basic criteria on how you go about selecting your patients for topo-guided PRK? So essentially in topo-guided PRK, we want a minimum thickness of at least 450 micron, or if you want to put it in another way, in the postoperative period, that is once your ablation is done and the epithelium is grown back, you want to leave the patient behind with at least 400 microns. So this is how we select a patient as far as thickness is concerned. Ablation, yes, to a certain extent, it is dependent on the thickness, but we do not exceed beyond a certain limit. That is 50 microns is what was originally given as the guideline. But generally, if the thickness is very good, we may, there are publications which have extended it up to 60 to 70 microns and then done a cross-linking and have shown it to be safe. In these patients, as we said, regularization is the key. And we might even bring down the optic zone size from the usual 6.5 to about 5.5 millimeter, which will reduce your ablation depth and therefore give you a little more tissue saving. Target refraction. I'll talk a little bit more about it in the subsequent slides, but we have to remember here that emmetropia is never the goal. We are also doing cross-linking, which itself, as Gitansha explained, depending on the type of cross-linking, whether it's accelerated, whether it's conventional, or whether it's customized, has its own flattening effect. So here you don't want to bring the patient directly towards emmetropia or to emmetropia, but you want to give them a certain undercorrection of 20 to 40%. How do we go about it? I'll talk to you all in a subsequent slide. Centered versus decentered, it does definitely work better for centered cones. If it's grossly decentered, you're probably better off giving them, leaving them behind with contact lenses or using a procedure like intracorneal ring segments. Topo-guided treatment works best if the cone is best centered. Conventional versus topo-guided. Now, do you actually have to always only have a topo-guided instrument to be able to do this particular treatment? Yes, topo-guided works better. But then there are publications where they've seen when topo-guided laser is not available, by even using a conventional laser over the apex, that is a wavefront optimized delivery over the apex of the cone, has also been given good results. Just running you through some examples where you can see there's a much better improvement in symmetry. The BCVA has also improved. The residual refractive error has also come down. Again, you can see an excellent improvement in symmetry. Improvement is best in the uncorrected visual acuity. The improvement in BCVA is not as much because these are mild to moderate cases of keratoconus where the BCVA is already somewhere between 6.6 to 6.12. So the UCVA is where the patient really sees the marked improvement in the quality of vision. And it works best in centered nipple keratoconus, as I mentioned, where you can see here that the keratoconus has almost disappeared, and this is one of our very happy patients with a plano 6.6. Now, do you go subjective versus topo modified refraction? This is a major question which has always been asked in various podiums, where basically you want to go ahead and do a topo guided treatment, but what about the residual tissue? Do you correct based on the subjective refraction? Do you go by the topography refraction? Because how much time do I have? 5 minutes, okay. So in terms of, let us look at this case example. I'm not sure if it's visible to the people in the back, where the refraction just gives you a 1 diopter of cylinder at 90, whereas the topography measured cylinder is 6 diopters at 168. Completely different axis, completely different measurement. What we have started doing, and after analyzing our results, what I found to be useful is that if you have a patient with a good BCVA, who is very well adapted to their cone. Many of these patients, the keratoconus progresses gradually, they are very well adapted. You might have what looks like a fairly moderate to advanced keratoconus, but the BCVA will be excellent. Let us not play around with their topography too much. Just give them some regularization, a little bit of cylindrical reduction, and that's all the tissue will have anyway, and leave it at that. But when you have a patient whose BCVA is poor, that is when I ignore the subjective refraction. That is where the subjective refraction is totally unreliable. Go ahead with only the topography guided refraction. Go ahead with the axis of the topography. Put the magnitude somewhere between your subjective and the one measured on your topography. And this gives the best results in most of these patients. The next question is, do you want to remove the epithelium manually, or do you want to use a PTK to remove the epithelium? I just want to show you this particular case example, and it's not uncommon to see this in your patients of keratoconus, where you'll have a thin epithelium over the apex of the cone, which becomes progressively thicker around the base of the cone. So if you, now you must remember that you're measuring the topography with the epithelium on. And if you remove this irregular epithelium manually, the topography underneath it is completely different from what it was with the epithelium on. So you probably are better placed until you have a good Bowman's topography, which Dr. Himanshu might add upon later. Unless that device becomes commercially available, you're probably better off just removing a uniform 50 micron epithelium all over, so that the topography underneath mirrors the topography which you would have measured in your preoperative period, and then go ahead with your topo-guided treatment. The safety, efficacy, and long-term stability has been well established in multiple studies. These are our own results. As you can see here, the improvement in UCVA is quite remarkable. The patients are very happy, whereas the BCVA, there's only a subtle improvement. But there are still unanswered questions. What is the maximum level of ectasia up to which you can offer this? What is the lowest pachymetry you can go to? Yes, we are sticking to that 400 micron guideline, which has been set so many years back. But does that hold today, good today with the advances we have in cross-linking? And finally, what is the dosage of cross-linking to be administered? These are exciting days where very soon the customized cross-linking will also become commercially available. And once it does, combining these topography guided treatments with customized cross-linking will be the future, which will augment your results even further. It's a promising procedure, which I think all of you must go back and start trying, and especially in early mild to moderate cases, and definitely gives them a significant amount of spectacle independence, and these are truly happy patients. Thank you so much for your kind attention.